fingers crossed it's better than it was last.
It would be pretty easy for someone with my background. As I began to get into it, I found out that I really didn't know very much about this at all. As those of you who have attended my talks in the past know, that when I talk about drugs, I tend to talk not just about what the drugs do, but about the mechanisms underlying these effects. You'll get a little bit less of that because it's extremely complicated, and I'm not sure I'm qualified to really dig into those mechanisms very well. However, one thing I am qualified about is to talk about weight and weight loss, because personally I've struggled with this most all of my life, mostly losing the struggle, and presently, as I'll demonstrate later on, I'm far from perfect right now. So let's get started a little bit about the problem of weight, and I have some obesity statistics. They're probably a couple of years old, but 73% of the people in the United States are overweight. That's 3/4 of us. 42% are estimated to be obese. 9% severely obese. That's almost 1 out of every 10 people. 1 billion people in the world are estimated to be classified as obese by 2030. 1 billion people. Boy, that's a big market for these drugs. And annual costs of obesity in the United States are estimated to be $173 billion. That's a 2022 estimate, I believe. So there's a lot of it out there. There's a lot of us, a lot more of us than we need, perhaps. Well, how do you define whether somebody is overweight or obese? Don't know about pronouncing this guy's name, but in 1830, Quetelet, a Belgian mathematician, set out to describe the average man. And he was a very versatile guy. He was also a sociologist. He was an astronomer, and in fact, he headed the big astronomy building in Belgium. Well, he took thousands of measurements to find the ideal weight and height, and then applied a simple mathematical formula to convert this to numbers. Now, he had no interest in obesity when he was doing this. This was part of his sociology background, where he was really trying to look at what would be kind of an ideal description for a man. And this became the body mass index, which is still widely used today in defining weight characteristics, despite the fact that it's rather simple and has a lot of problems with it. So it's a simple way to classify body types into categories. And calculations of this can be done quickly using either the metric or the English system. It was worked out in the metric system, so when using the English measurement, ounces and fractions of inches have to be changed to decimal values. And then it's just a very simple algebraic formula where the body mass is calculated by dividing the weight in pounds, if we're working in the English system, by the height of inches squared, and multiplying that by a conversion factor of 703. Well, when you go to the doctor's office and he's interested in calculating a BMI, he's certainly not going to sit there and do this very simple algebra. This has all been tabled. And so here we have a typical table. If we look at At this ordinate, we can see that we have both inches and centimeters. And then if we go across too far across the top, we went too far across the top. We have the weight in pounds or in kilograms. And if we look at this other ordinate, then we see the classifications, and they're color coded. And 5 categories here, being underweight in the light blue, green in the healthy, yellow in the overweight, obese in the mustardy color, and in the red, severely obese. So to see how this works, let's take the magnificent physique of Donald McMillan. At one time, I was 5 feet 8 inches tall, but I've been shrinking. I'm down to 5 feet 6 inches tall. So if we go here and start from my height, and then my weight, which the last time I measured was 167 pounds. Now this isn't quite detailed enough to do decimal points, but if we were then to go out to 100, and unfortunately have to keep going, let's do 170 pounds. I would fall in the middle of the yellow, which is overweight. I tried to go down to a little bit taller height like I used to be, but I still couldn't get out of the yellow. I was still overweight. If anyone wants to volunteer for the group to see their own classification, I'd be glad to calculate it. As I suspected, the number of takers is quite limited, somewhere near 0. So anyhow, that's the BMI. Now, there are weaknesses in this measurement. It fails to differentiate between males and females, and probably that's primarily due to the differences between muscle and fat in male and female bodies. Nevertheless, when physicians are using the BMI, they use the same formula for both. It doesn't account for age. As we get older, our muscles tend to waste and become less dense, and that is not taken into consideration. And then these cutoff points are subjective. I don't know who really set them up. So with all these problems, why do we use it? Well, BMI levels correlate fairly well with the development of a number of disease states. As the BMI rises for a particular age, so do the medical problems. Second, as you can see in my just doing the calculation on myself from the table, it takes very little time and effort to perform, and the expense for doing it is practically 0. I was going to actually do a calculation here, but I think the table handles that quite adequately. So, areas where obesity produces major effects on health, and I'll go over these briefly, but I think you're probably all aware of them. I think we all know that people who are overweight or obese have problems with hypertension, type 2 diabetes, obviously, coronary heart disease, stroke, osteoarthritis, sleep apnea, cancer. Now that's a kind of interesting one, because I don't think most people would feel that overeating causes cancer. I think that people who study cancer think of two factors. One is the initiation of the cancer, and secondly is its progression. And probably overeating doesn't have a lot to do with initiation. Some other stimulus or genetic factor starts the cancer. But there are numerous studies that have gone on to show that the progression of cancer correlates heavily with body weight. So people who are thin tend to have slower progression of many cancers. Depression and anxiety, that probably relates mostly to one's self-image and the impression one thinks that other people might have when they view them. Now, not on this list that I used and took from the literature was COVID-19. And so I looked into COVID-19, and probably it's a little bit like cancer in that eating probably doesn't have a great deal to do with the start of the COVID, but it probably has a lot to do with progression and with the serious diseases. That there are a number of papers that are showing that people who are particularly heavy are much more likely to be hospitalized and much more likely to die from COVID. Well, what are the treatments for weight control? I don't have all of them here, but the most common one is diet and exercises, lifestyle changes, and certainly I have tried that myself and had good results that last for a couple of weeks, and it disappears. Actually, the meals here are not helpful. Having opportunities to eat dessert and having a candy dish out there all the time and coming in mid-morning to obtain food is very challenging. Prescription drugs, and we're going to talk about that mostly the rest of the talk. Particularly these new drugs. Over-the-counter drugs. Well, a lot of people do self-treatment for a massive number of these drugs, and I would summarize in general by saying that they pretty much don't work. Surgery, well, that's really beyond the area where I want to talk about. Now, counseling. I think any kind of behavioral change counseling is important, and getting good counseling for weight control, I think, is particularly important. Okay, I want to talk about a little bit about the history of drugs in weight control. When I first started studying pharmacology, amphetamine was the main drug that was being used. Now, this is not the methamphetamine that we hear about being such a big problem for problems on the street and addiction. This is dextroamphetamine. Amphetamine is a racemic mixture of the D and L isomers, and these isomers can be studied, and it's the D isomer, the dextro isomer, that had the effect. It's a central nervous system effect, and it cuts the desire to eat. However, it has considerable effects in the central nervous system that are undesirable, as well as the cardiovascular system. It increases blood pressure, increases the rate of the heart beating, produces stimulant effects, tremors if taken in too much it can, too much of a dose, it can produce convulsions. And it's also addictive. Not as addictive as methamphetamine, but still pretty much. Now here's another one that I have trouble pronouncing. This is trouble when you read the literature and you don't hear somebody who knows what they're talking about pronounce these effects. I used to, in teaching medical students, I used to use a lot of programmed instruction, and then when I would come and talk to them, they'd say, would you pronounce these for me? Because reading, you don't hear it. So I'm going to take a shot at this, and maybe if somebody knows the word better than me, they can educate me. But I'm going to say casemia has been adduced, and it's a combination of phentermine, which is an amphetamine derivative with much less effect on the central nervous system, and topiramate, an anti-epileptic, and with many of the same deficiencies as amphetamine for this combination, perhaps a little less in the way of side effects, but in my reading, certainly not the answer. Another one that's come along recently, Contrave, is a combination of bupropion. This blocks the reuptake of norepinephrine and serotonin, and as such has antidepressant effects. And naltrexone. This is an opioid receptor antagonist. It's not the one that we hear about on the streets, but it has very similar effects, but a much longer duration of action. Presumably, it works by reducing the pleasure of eating by blocking opioid receptors, which are involved in the central reward circuits. These drugs, they work moderately well and for short times, but they also have some undesirable effects. The sympathomimetic effects of the drugs, naltrexone blocking opioid effects for a day sometimes. You could be in some trouble if you needed to have some pain control. There are other drugs coming on the market that we won't discuss because I want to focus mainly on the GLP-1 agonists, a group of drugs that have a history of use in treating type 2 diabetes and are now the rage in the treatment of weight control, and a lot of problems are developing with that. Well, what's this GLP business? Well, the G stands for glucagon. It's a peptide hormone that's secreted from the pancreas. And one of its major roles is to increase sugar stored in the liver. And it works in combination with insulin. When your blood sugar falls due to insulin release, hypoglycemia can result with serious consequences. And maybe if we have time, I can talk about an experience that I had with someone having this. Glycogen acts at glycogen receptors to prevent this fall by mobilizing sugar that's been stored in the liver. So the G stands for glycogen, and that's its major effect. It has at least related to weight control, has lots of other effects. So GLP stands for glycogen-like peptide. So it's really mimicking the effects of glycogen to produce effects similar to glycogen. And there are glycogen receptors to produce these effects, and they're found in many peripheral tissues in the body, and they're also found in the brain. So it works in complex ways in diet control. So if we give these drugs, the GLP agonists, bind to glycogen receptors. This mobilizes the sugar stored in the liver to be released, which triggers insulin release, and that converts food and calories to energy. So that's something that happens within the body when the drugs are given at a receptor level, mostly in the stomach. Stomach emptying is also slowed by GLP drugs. This is probably more important, that it slows digestion and causes a feeling of fullness. There's also direct action at GLP-1 receptors in the brain. I guess I should just call that GLP receptors in brain. Decreasing feelings of hunger. And there are also various feedback tracts from the GI tract to the hypothalamus, which is a major area of the brain that's involved with eating and hunger. This may be due to nerve feedback to the hypothalamus, or by the hormone leptin, which circulates in the bloodstream to the hypothalamus. Leptin tends to build up as we eat, and high levels of leptin in the stomach are associated with the feeling of fullness and a desire to stop eating. This I'm not going to go into any detail. I think you can already see that that these drugs have the potential to work in the brain, to work in the GI tract, to be involved in the liver, to mobilize the release of energy from muscles, to work in the stomach, and to work in the heart. And we'll touch on the heart a little bit later when we get into some of the individual drugs. So it's an extremely complex system, and you can see why I avoided getting into to the details, because that would take up most of the talk, and I'd probably screw it up anyhow. So, do the drugs work? Well, the information that's coming out is so slow. It's really hard to find good graphs that show it. This is the one that if you ask that question, that your computer's probably going to show you, and it's not a very good graph, because there are no numbers here on the ordinate. But the ordinate shows change in body weight in percent, and the abscissa is time in weeks. So this particular experiment was done on Wegovy, which is one of the most popular, maybe the most popular of these drugs that then with the bulk of them that are so popular today. Well, they don't put any numbers here, so I'm thinking we're probably talking about 20% of body weight on this ordinance. So this study was done in about 500 people, or I'm sorry, about 800 people totally, and all of them start out at week 1. They are all obese. There's a mixture of male and female patients, and you can see that there's a steady decrease in weight here, and based on what they put out here, you're not going to see me waving my finger. I have to do this. Probably a loss of somewhere 8–10% in 20 weeks. And in 20 weeks, they continue, patients, about 2/3 of them, continue to take that same dose, whereas the rest are put on placebo. And you can see that what happens is that the weight loss drops, further, and those that stay on, looks like it's starting to level off a little over a year's time, with a drop of somewhere 15 to 20%, whereas those who go on placebo after the 48 weeks on placebo, most all of the weight has gone back. Typical of weight loss drugs. Now, there are a lot of studies that are being reported with 5 to 20% weight loss with GLP-1 agonists, with the beneficial effects starting shortly after initiation of the drug, as you saw in that graph. And there's a lot of these drugs that are being tried. It's a big dollars market. And these effects are being reported across a variety of the agonists that are studied. When combined with behavioral therapy, some are showing weight loss in excess of 30%. Now that's a lot. You weigh 2 pounds, say you weigh 200 pounds, that's a loss of 60 pounds. Early data, though, are suggesting that the weight is regained when the GLP agonist is discontinued. So that in that respect, although it's more effective than any class of drugs that we've seen, the effects are dependent on continued administration, at least with those that we have so far. Now, there are lots of efficacy studies that are coming out, but the quality of these is marginal. They're mostly looking at our drug against their drug, and it's a single dose study, and we don't know where they are on the dose response curve here. So I tend to view these with a little bit of concern. There are some interesting studies providing data suggesting that the drugs are less effective in producing weight loss in patients with type 2 diabetes. And the reasons for that are unclear. Well, some effects, some limitations of GLP-1 agonists as agents for weight loss. Side effects. Mostly GI, not surprising when you're using a drug that is mostly working on GI levels. Diarrhea, stomach pain, variety of other GI systems. The history of the clinical use for weight control is short, and that's a disadvantage, but because these drugs have been around for a while in the treatment of type 2 diabetes, there's not great concern that there are going to be problems here. But the drugs that are coming out are new, and we just have to wait and see. Cost, and I'm going to talk about that a little more in a bit. Expensive, but the cost is dropping because competition is increasing. So many companies now are wanting to get involved in this because you saw in those early statistics that this is a big problem in our population. And so the demand is great, and everyone wants a cut. Some companies are trying to develop a direct-to-patient marketing system where it's not sold through pharmacies, but sold directly to the company, through the company. Other manufacturers are lowering prices. Now, another problem is most of these drugs currently are given parenterally. You have to take a shot. But oral forms are under development. It's hard to get these drugs because they're short supply and high demand. FDA has some prescription control. Currently, the recommendation is that The drugs require a body mass index of 30 and up, or 27 if they have a disease state where existing disease outcome is affected by obesity. But many physicians are doing off-label prescribing of these drugs for weight loss. A little more about symptoms. 3 columns here, adverse events, and first, whether they're common or whether they're rare. The GI symptoms, nausea, diarrhea, constipation, pain in the stomach, those are very common, that they tend to disappear with a few weeks of administration of the drugs. Cardiovascular, there's a small heart rate increase, but it's insignificant, about 3 beats per minute on average. Allergic antibodies are detected because you are giving a peptide here. But aside from maybe cutting the efficacy of the drugs for type 2 diabetes, this has not proved to be significant yet. Kidney damage, rare but much more serious. Acute damage that's secondary to the effects on the GI tract. Blood, hypoglycemia, and I want to talk about that a little bit more later. And then there have been a few reports recently of thyroid cancer, and I don't know whether that's real or not, whether it's caused by, although thyroid cancer is obviously real, but is that due to being on these drugs or due to something else? And that's not apparent yet, but it's something that's of concern. Okay, here's the dollars. Wegovy, Saxenda, Ozempic. These are monthly costs. So when you're looking at something in the neighborhood of 12,000 and up per year for some of them. Dose frequency, once a week, daily, once a week, depends on the drug. And right now, Ozempic is cleared only for type 2 diabetes, but it's very popular being done for weight loss where diabetes is not involved. Okay, what about your insurance? Okay, will that pay for it? Medicare Part D prohibits the coverage of weight loss drugs in general, and that was a law that was passed in 2003. However, in some states, Medicaid provides coverage, and I could have given a list of the states, but I couldn't find anything on Washington. Many private plans do cover, but there are some restrictions under the conditions. But there's a very high public awareness of these drugs due to the publicity they're getting off and on. I think you can hardly pick up the local papers and not find something about them at least once or twice a week. And your television is bombarding you with information about these drugs. And because the off-label prescribing has led to a shortage of the drug, fake GLP drugs are already appearing on the illicit market. Plus, there are some pharmacies that are compounding their own using the semaglutide, which is a scientific name for the active ingredient in a couple of these drugs. Now, the original preparations that came from the companies that first developed them for this used injectable pens. They were parental, you had to inject them. And they could shoot the drugs, and with these injectable pens, the dose was controlled. So, you know, one squirt, one dose. However, these preparations that are being prepared by some of the pharmacies are just compounding the drugs, and they're coming in multiple dose vials, and then it becomes much more up to the user to administer the dose in the proper amount. And I read one case where the dose was supposed to be 0.01 mils, and the person injected 1 mil. So, and then went into serious hypoglycemia, was rescued and did not die. But if you just give them a vial and a syringe, problems. So that's the heart of what I wanted to give you, and then I had some questions for the future. Should the cost of these GLP-1 agonists be controlled? Should the government get involved? They're very likely, I think, to become abused. Should they be used widely for weight control without more detailed testing? They're not undergoing the usual clinical trial stuff over years that we're used to. Should they be sold over the counter? How should we define overweight and obesity for the use of these drugs? Is BMI an adequate diagnostic tool for setting the limits? Certainly that's what they're using right now. Should counseling be required as part of the treatment program when these drugs are used? What about cosmetic appearances of these drugs? Should they be sold for cosmetic appearances? As I indicated, I'm a bit overweight. I like that word "bit" in there, but I'm a bit overweight, and should I go ahead and use one of these drugs if I can get a physician to prescribe it? I'm definitely not obese. At least that's the way I see it. How long should the use of these drugs be continued in individual patients? We probably have some that are approaching 2 years. Is this going to be a treatment for people with obesity? If it works, are we going to keep them on there? Is it like methadone? Is it like blood pressure drugs, where once you get on them, you're probably going to stay on it? I think it's a lot like blood pressure drugs because many people who develop hypertension do stay on them for the rest of their lives, but many other people are able to get their weight down, and with other treatments are able to get off the drugs. And that possibility is going to exist, I think, for these drugs, that perhaps once you get your weight down, maybe you can get off them and use diet and exercise and so forth to stay on them. We don't know any of these questions because we're looking at something that's out there about 2 years old now. And will the beneficial effects of these drugs continue after use is discontinued? Certainly. The early data are saying that the answer is no. So I'll just open it up for discussion, and on these, or any other thoughts that you have about them? Get some lights maybe, please.
So Don, about 4 years ago, I was diagnosed with type 2 diabetes and put on a prescription of a thing called metformin.
Mm-hmm.
And I found that over the course of a little over a year, I had lost 20% of my weight. And to the point that I was wondering, oh my God, when is this going to stop? Am I going to just vanish? So, and it is a pill. So, is metformin one of those kind of?
It is one of the drugs in that series, yes.
Uh-huh.
And if I can go back to the very early part, it looks like that is leveling off.
Absolutely, yeah.
But again, the ordinate and abscissa on this graph is so imprecise, it's hard to say. But,
Yeah.
I'm sure you know this, Don, but metformin is one of the drugs used for diabetes, although it's occasionally had a problem of causing too much hypoglycemia. But it also seemed to work because people got suppressed appetite, but it was because of a side effect, which I can't remember the name of, and so forth. But it worked pretty well as long as people are careful of it and so forth. And it's not as expensive like this, and you take a pill.
yeah.
But it's something you'd probably have to take under a doctor's supervision, like
Yes.
he did.
Yeah.
A problem, a social problem that is almost as extreme as obesity is alcoholism. And my understanding is that these drugs limit an interest in alcohol on the part of people who have a tendency toward alcoholics.
I can't comment on that because I hadn't run across that data in my research. So how they, of course, alcohol has calories. So.
I'm here. It's okay.
Yes.
You mentioned our diet here, and the meat is often very fat. We get lots of carbohydrates and desserts, as you say. I finally learned to ask for a half order from time to time, because normally I find they give me more food than I really want or need. I used to eat pretty heavily, but as an older guy, I don't have the appetite I once did.
Yeah, I was brought up in a household where a clean plate seemed to be something that would perhaps get you into heaven. And so it's very difficult to leave food there because this is conditioned into my brain now. Walking past the candy dish out there without taking something is that's very difficult too. So.
The chocolate always disappears first.
Is metformin ever prescribed for weight loss?
I don't believe so. It would have to be off-label. I haven't seen much in the way of that advertising it specifically for weight loss. Now, I don't know why. perhaps part of what's going on here is that these new drugs are all coming on that are getting around the patent. And I didn't look into metformin to see what its patent control was.
Don, are the causal factors in young children that are overweight similar to the ones that were shown?
Are the causal factors? I know that the drugs are being prescribed for children, that there are studies in them, but I haven't read anything really about what's causing them in children.
So Don, is there a large identifiable part of the population that has what is termed the healthy weight, and are they healthier?
Well, I think that there's a lot of data that shows that people who have a so-called healthy weight are healthier, and that when they do contact a disease, the progression of that disease is much slower. There's also all kinds of statistics available about racial groups, countries, so forth, tons of data on that.
You just mentioned countries. I've been in bits of Africa and South America and seen virtually no fat people. So there's certainly lifestyle. Some of them are Caucasians, pretty much like us. Others are different racial groups. But I think this whole business of snacks for everybody all the time is probably a big factor here.
Well, some populations, of course, there isn't enough food, and that would be a main reason there. But there are a host of complicated issues that go into this. It's, I think so many of the questions that come up with eating and drug abuse are so similar that we know what we're doing is not good for us, and yet our ability to stop is also very difficult for a lot of people, and the fact that we can stop for a little bit sometimes on these, and then we go back again. That's common with addiction problems, and it's common with eating problems. And there's just a lot of similarity there. Yes.
It's really not worth that much, but I recall now thinking is that the metformin, the side effect was getting some mild ketosis, which suppresses appetite too, and that was one of the things you used to have a diet that gave you high fat, and it worked because it caused ketosis, more like borderline diabetic acidosis. But those are the people, they stopped doing it after a while, just like most diets, after a few weeks regained weight anyway.
I mentioned that I had an experience with this, not personally, but with someone else when I was a graduate student working in a lab where we were doing a lot of work with brains. We had hired a dental student to come in and prepare slides for us, and he didn't eat like he should have, and so he went hypoglycemia. He's a very quiet, reserved young man, and I'm walking down the hall, and he comes running at me, and he attacks me, and he's laughing and yelling, and then he goes down on the floor, and he's out. And we knew he was a diabetic, but how are we going to get sugar into him? He didn't have any sugar around it, and but I remembered we had orange juice in the refrigerator, and we had a dirty old sponge for washing dishes. So I went and got the orange juice and the sponge and soaked the sponge in the orange juice and squeezed it into his mouth. And I think it's probably one of the most dramatic kinds of things that you can see in medical science, where somebody is down and out, and within a matter of minutes he's back up and talking. It's very much like naloxone against opioids, where you can hardly get the needle out before you see the effect occurring.
You mentioned cosmetic use, and our culture has this obsession with hourglass figures and young women who are just ultimate beauty, and whole industry is to deal with this. So it doesn't surprise me that there's a lot of cosmetic use.
Yeah, I had kind of osmotic figure with the broad shoulders and so forth, but the sand all ran down at some point.
Yeah, that's total hourglass figures.
Does that kill all the discussion? Thank you.